Hey everybody, it's Dr. Dave, Psychiatry. Thanks for coming to the YouTube channel today. I saw a patient this morning that reminded me of a topic that I think is actually really important for a lot of people. Whether you're female and have this problem or male and know people that have this problem, having emotional and psychological problems around your period, your menstrual period, is a problem. So people typically know the term premenstrual syndrome, PMS. And the patient I saw this morning told me a story that she had seen her OBGYN, her obstetrician, gynecologist, nurse practitioner, who had diagnosed her with PMDD, which stands for Premenstrual Dysphoric Disorder, which is essentially a severe form of PMS that is talked about really as something that requires medication. So she said that she didn't want to do anything until she talked to me, so we talked it through, and I said, you know what, I probably should make a video at this because it's a pretty important topic. She said, that's great, you should do that. So thanks to her, we're talking about that today. Premenstrual dysphoric disorder, if you understand what the words mean, pre, before, menstrual, around your cycle, female menstrual cycle, dysphoric, which means not feeling good, and disorder means problem. So PMS, premenstrual syndrome, even though it's a problem for a lot of people, it doesn't rise to the level of what we call a disorder, which means it's a problem. So in some sense, PMDD, I think historically, and this is my opinion only, but historically I think PMDD has been a really easy go-to diagnosis for an obstetrician dealing with a woman who has lots of depression symptoms that are worse around the menstrual cycle. And instead of talking to patients about depression, which as we know and I've talked a lot about on this channel, the word depression scares people. And a lot of doctors are reluctant to talk about depression, so they don't want to launch into that and say, hey, I think you've got depression, because that conjures up lots of ideas and people think, well, I don't want to deal with that, or I don't want to be sent to a psychiatrist, or no, I'm not crazy. I mean, honestly, I really feel this way. So the truth is, I think instead of addressing the disorder aspect as clearly as they could with depression, I think a lot of OBs and people in that area have gone to premenstrual dysphoric disorder as a way to get people to talk about their depression symptoms in relation to their cycle. Whether or not it's in relation to the cycle, it's a problem. So when you start talking about medication treatment for PMDD, the typical treatment program has been using medicines that boost serotonin. So Zoloft is probably the number one medicine that's suggested, and that's a serotonin booster. And if you want to go back and review the first parts of the channel to learn more about depression and medicines that boost serotonin and look at me drawing pictures, you can do that. But for today, I'm just going to use my hands and say, the deal is if your serotonin is below the normal range, so if you're listening to this and not watching, I'm holding up my hand with the normal range on my left and using my right hand to talk about the level of your serotonin. If you are low, below the normal range, you're not going to feel good. And those symptoms can be the range of anxiety and depression, but we talk about depressed mood, low interest, low energy, low motivation, not eating well, not sleeping well, feeling emotionally fragile, sometimes having thoughts of being dead. Those are all part of that low serotonin. In relation to menstrual cycle, a lot of times that's feeling agitated, upset, anxious, tearful, fragile. But why do we think that that's related to serotonin? Because that's not really the depression symptoms. Well, some of them are, some of them aren't. Typically, people don't talk about profound depression during PMDD. They talk about fragility and being easily frustrated and, quote, set off and things like that. The reason we talk about serotonin being maybe the problem is that, guess what? Zoloft is a serotonin booster. So if your serotonin is here and we push your serotonin up to here and your symptoms are relieved, guess what that means? That means that serotonin shortage was your problem. So again, in classic, troubleshooting brain chemistry fashion, you really look at the results of the experiment. If the experiment is you do better with a serotonin booster, then you probably had a serotonin shortage in the first place. Now, if you're not female and you have those symptoms, well, what do we do? If it's not about your menstrual cycle, if your serotonin's here, we give you a serotonin booster to feel better. If you're female, let's say you're of past your postmenopausal. So you're not having periods anymore. If you're here and Zoloft helps you, then serotonin shortage was your problem. If you are menopausal and you're here and we take a medicine like Zoloft and push you to here, get you to the normal range of serotonin, and your symptoms get better, then that means serotonin shortage was your problem. Now, the reason that this is really important is that the patient today told me that it was suggested to her that she could take Zoloft for 2 weeks around her period. And that didn't make any sense to her. Well, that's because she's my patient, so I teach all my patients working together my thinking about this, and she said, that doesn't make any sense to me. If the medicine takes a couple of weeks to work, why would it not, why should I do that? Or at least she said she wasn't comfortable with it. I think I was the one that layered in that it wouldn't make any sense. So maybe I'm giving her credit I shouldn't give her. But she obviously didn't, she said it didn't make sense to her, so she asked me, is that really true? And in my opinion, even though I'm sure there's a lot of OBs out there and OB nurse practitioners that do that give medicine around the time of their period, a week before, a week after, physiologically what we know is that the serotonin boosters don't work right away. So if you take it for 2 weeks out of the month and then stop it, you basically go back to square one every time, and you don't really get enough time to hit the target that I think you should hit, because typically we look at 2 weeks as when you should really start to feel something from serotonin boosters, but you typically look at a month as the solid picture, and a lot of times you look at 2 months as the final determiner of, is a serotonin booster enough for you? So, for example, if 50 of Zoloft is not working at 2 weeks, I don't care too much. If it's not working at a month, then I'm thinking we need to raise it. If we get all the way to the dosage range of 50, 150, 50, 100, 150, 200, at 200 I might say, look, let's at least do this for 2 full months before we do anything different. And that's because we know that the increased time up to about 2 months is about what you can expect from a medicine in the serotonin boosting category. So it didn't make sense to her to only take the medicine 2 weeks a year. It doesn't make any sense to me. So what I said to her, even though she decided she was not going to pull the trigger on that today, she had made some other changes with her OBGYN, and she wanted to see how those other changes worked for her, which is great. She said when she comes back in next time, if there's a problem still around her period, which she believes will be, but she didn't want to do it today. So if it's still a problem when I see her back in 2 or 3 months, then we're going to probably try the Zoloft as was suggested, but we're not going to do it every 2 weeks around her period. We're going to put her on it and take her serotonin from here to here and leave it there. Now, I'm sure there's OBGYNs that might watch this someday and say that's not how they do it, but in my office, that's how I do it, and I do it that way because that's how I get the most success. So, PMDD, perimenstrual dysphoric disorder. Probably another thing to emphasize is that really we're talking about a disorder that's in the context of a stress. So one of the reasons that you might or might not talk about PMDD, but just might talk about depression or generalized anxiety, any of the conditions that get caused by low serotonin, any of the conditions that get better with a serotonin booster, well, the diagnosis of PMDD is sort of around the topic of the stress of your menstrual cycle. In other words, if you're not doing well around your menstrual cycle, is it because your serotonin's here, it's normal, and that stress is just overwhelming? Possibly. Or is it that your serotonin is low, below the low line, and you're not dealing with it because your serotonin's low? Medically, that would be the way to test that would be to give a serotonin booster. Because if your symptoms get better in the face of the stress, if you go from here to here and you manage the stress of your menstrual cycle better, that means that chemically your problem was shortage of serotonin as opposed to just being stressed out. So in that way, PMDD is really no different than any other condition or any other situation where we talk about the circumstance does not cause the chemical disorder, but if you don't have good chemistry, you won't deal with the circumstance as well, whether that's your menstrual cycle, your finances, your relationship to other people, your relationship to exercise, your relationship to food. Typically, you don't do well when you're here, when you're low. So medicines that boost that to where you're normal, all aspects of your life get better. if that's your problem. Not saying that everybody needs serotonin booster, but if your serotonin is low, then boosting it is going to be good for you medically. So that's what we talked about today. That's my approach to PMDD, perimenstrual dysphoric disorder. I hope that's helpful to you. And thanks for coming to see me today. I'm Dr. Dave, Psychiatry. We'll see you again soon.